Bismillahirrahmanirrahim. My name is Dr. Mustaqim Shah, and in this lecture we will be talking about ulcerative colitis. Well, ulcerative colitis is one of the type of inflammatory bowel disease. Ulcerative colitis is the disease of rectum and colon with extra-intestinal manifestation. The incidence is 10 for 100,000 per year in the UK. It affects both men and women, and the peak age is 20 to 40 years of age. It is most common in USA and Europe. The exact etiology is unknown, but there may be some genetic contribution because 10 to 20% of patients have first degree relative with inflammatory bowel disease. There is also a hypothesis that there is a reduction in the number of anaerobic bacteria in people with ulcerative colitis, but the specific organism is unknown. Unlike Crohn's disease, smoking seems to be protective. We know that smoking aggravates almost any kind of disease and causes cancer in almost any organ of the body. But there is only one disease, which is called ulcerative colitis, in which the smoking seems to be protective. In the pathology, we know that the diseases start in the rectum and it extends proximally in continuity. The disease continues. It will involve the continuously whole of the alimentary canal. But in the Crohn's disease, we know that the lesions are skipped. The colonic inflammation is diffuse, confluent, and superficial. Superficial means that only mucosa and rarely submucosa are involved. It does not go deeply into the muscularis and serosa. Pseudopolyposis are seen, and the strictures are uncommon in ulcerative colitis. This point is important that a small proportion of patients developed irregular mucosal swelling, dysplasia-associated lesions, masses, which are highly predictive of coexisting carcinoma. Wherever there is a dysplasia, it points toward the carcinoma. The symptomatology depends on the extent of the disease. More extensive the disease, more worse the symptoms will be. If more area of the rectum and colon is involved, then the symptoms will be worse. And the main symptoms is rectal bleeding and mucosal discharge. So, wherever there is bleeding, of course it will cause anemia, iron deficiency anemia, and blood loss anemia. The disease is classified on the basis of severity as mild disease, moderate, severe, and pulmonary disease. In mild disease, the frequency of stool is less than 4 per day, with or without bleeding, and no systemic sign of toxicity. No systemic signs of toxicity. In moderate disease, the frequency of the stool is more than 4, but there are few signs of systemic toxicity. In the severe disease, the frequency of the stool is more than 6, and there is systemic illness. And the hypoalbuminemia is common. In the pulmonary disease, the frequency is more than 10 bowel movement. And there is also progressive colonic dilation, toxic megacolon. The extraintestinal manifestation include arthritis in 21% of the cases, and apart from the rest, also erythema nodosum and pyoderma gangrenosum is seen. The cancer risk depend on the duration of the disease and the extent of the colonic involvement. After the diagnosis within 10 years, the cancer risk is very minimal, almost 1%. But it increases 10 to 15% in the 20 years and 20% at 30 years. And the colonoscopic surveillance with dye spray or multiple biopsy every 10 centimeter is undertaken to look for subtle mucosal abnormalities which can occur in flat mucosa or den. In the investigation, first of all, we do full blood count, and anemia is seen on full blood count. The serum albumin will be low. The ESR and CRP will be raised. The colonoscopy is one of the most important tests that we do for ulcerative colitis. On colonoscopy, the polyps will be seen, and the mucosa will be hyperemic and bleeds on touch. The ulcer can also be seen. So, what does the colonoscopy tell us? The colonoscopy is done to establish the extent of inflammation, but the colonoscopy is contraindicated in acute colitis because there is a risk of perforation. To distinguish between ulcerative colitis and Crohn's disease, to monitor the treatment response, or to assess the long-standing cares of malignant changes. This is a picture of colonoscopy from ulcerative colitis. These small polyps and hyperemic mucosa can be seen. In the radiological test, we perform the X-ray abdomen, which will show us toxic megacolon, barium enema, and CT scan. This is a picture of the toxic megacolon of the transverse colon. This is the X-ray abdomen, and it shows us the megacolon. This is a picture of the barium enema, and you can see that the hastration in the colon is lost, and it looks like a lead pipe. This is called lead pipe appearance of the ulcerative colitis. Well, as we all know that the ulcerative colitis is an inflammatory disease, so the treatment is directed against inflammation. So first of all, we give 5-aminosalicylic acid. The steroids are a mainstay of treatment for flare-up either topically or systemically. We also give immunosuppressive drugs, azathioprine or cyclosporine, to suppress the immune system. We also give monoclonal antibodies like infliximab, adalimumab, which act against the tissue necrotic factor and prevent the inflammatory cascade. Well, the surgery is indicated in severe or pulmonary disease, when there is anemia, or if the patient is steroid dependent, or if the patient is unable to tolerate medical therapy, and of course, if the patient has neoplastic changes like dysplasia, so then we go for surgery, right, for surgery. Or if there are extraintestinal manifestation. Operative treatment include emergency treatment, which is a subtotal colectomy and ileostomy. So in this procedure, we cut down the colon and perform, and a stoma is performed. The surgery has the advantage that the patient avoid pelvis surgery while unwell, and then we can do the restorative surgery if the patient is become in good condition later. In the elective surgery, we do protocolectomy and permanent and ileostomy, restorative protocolectomy with ilioanal pouch, and subtotal colectomy and iliorectal anastomosis. This is subtotal colectomy and ileostomy. The colon has been cut down here, and then a stoma is made. A stoma is made. This is the protocolectomy and permanent and ileostomy. The rectum and the colon is cut down and a stoma is made. In the restorative protocolectomy with ilioanal pouch, we cut down the rectum and colon, and then we make a pouch from the ileum. You can see this pouch is made from the ileum, and this pouch is connected with the anal canal. But this procedure is performed in people in which the anal sphincters are working. So this ileal pouch has the function of storage of the fecal material, and it has the advantage that the stoma is not made. There are various type of pouches like J pouch. You can see this is J-shaped, this is S-shaped pouch, yes, and this is a W-shaped pouch. Well, what are the distinguishing features between ulcerative colitis and Crohn's disease? And I think this is the last slide. So the ulcerative colitis mainly involve the colon and rectum, but the rectum is always involved. And the perianal disease, fistula and strictures all are rare. It involves only the mucosa and submucosa. The granuloma and fissures are uncommon, but the crypt abscesses are common. Coming to the Crohn's disease, it can involve any part from mouth to anus, but the ileum is most common. Remember, ileum is most common. The rectum is often spared, and this is a very aggressive disease, so it can cause perianal disease, fistula formation, and strictures. And it involves the full thickness, so it causes knife-like lesions. Granuloma are common and fissures are common, but the crypt abscesses are rare. So this was all about ulcerative colitis. I hope you guys enjoyed this video. If you enjoyed this video, please give it a thumb up and subscribe to my channel. Thank you guys.